Sorry, Dan. Welcome everyone to our, I don't know what it's got to be, the 7th or the 8th of this Ultrasound Journal Club national joint venture between ACEP and SAEM. For those who have not been a part of this before, it contains 3 sections. First, we're going to have a 30-minute discussion with the incredible Dr. Jennifer Marin, who's going to discuss her groundbreaking research, more of a landmark article now on POCUS for abscesses. Then we're going to have a 30-minute breakout session where we're going to talk about the randomized controlled trial of ultrasound for shoulder dislocations. The last hour, which is optional for anyone who's interested in staying on, we have a off the recording discussion about research. You talk about any ongoing research challenges you've had. You pick the brain of experts, figure out with your existing ideas, studies, how we can improve them and learn together. And so with that, we're going to get started with our first piece. So I want to introduce Dr. Jennifer Marin. Dr. Marin is an associate professor of pediatrics, emergency medicine, and radiology, bridging all 3 together at the University of Pittsburgh School of Medicine, and the hospital-wide medical director for point of care ultrasound at UPMC's Children's Hospital of Philadelphia, or of Pittsburgh. During and after completing her pediatric EM fellowship, she received POCUS training under the guidance of Drs. Anthony Dean and Nova Panebianco at the University of Pennsylvania. She's had numerous publications in the field of pediatric POCUS, and most notably in 2015 was the co-lead author with Risa Lewis on the first multi-organizational policy statement on pediatric emergency ultrasound. And so today, we're going to be discussing one of the key papers talking about the role of pediatric ultrasound, and it's entitled Emergency Ultrasound Assisted Examination of Skin and Soft Tissue Infections in the Pediatric Emergency Department. This was an academic emergency medicine published in 2013. So with that, I'm going to welcome Dr. Jennifer Marin.
Thank you so much, Mike. It's such a pleasure to be here.
And we're so thrilled to have you here to discuss it. And so the first thing I want to know is just tell us what prompted this study? How did the idea first arise?
Yeah, so when I started my fellowship, you guys have to sort of suspend your imaginations here and go back more than a decade when, in emergency medicine, point of care ultrasound was arguably standard of care. And in pediatrics, this was absolutely not the case. So very few programs were actually using it. No fellows were being trained in it. And my first month of fellowship was actually on the adult trauma side. And so I became exposed very quickly to the FAST exam and was very mesmerized and, sort of in awe of this tool and wanted to learn more about it. And that's really when I got to know AJ and Nova, and they were kind enough to take me under their wing. Because I was exposed early on, I thought, I would like to do something involving point of care ultrasound as my fellow project. So as pediatric emergency medicine fellows, we have to do a fellowship project. And I was very interested in research. I was planning to get a master's degree in epidemiology. And so we decided to design a study. And, with fellows, we have to be very careful that we are taking on something that's feasible, right? So you want to publish this great study that's going to impact practice and that people are going to then go and cite. But the reality is to get that done in such a short period of time is super, super challenging. And so fortunately, I had very good mentorship, and they helped me to create a study that was what we thought was going to be very feasible within that 3-year time period. At that time, there were 2 studies that had already been published in the general EM world. I'm sure everyone's familiar with the Squire study and the Vivek study, both of which were published in academic emergency medicine, and really were the studies that really demonstrated that point of care ultrasound could be used for soft tissue evaluations. And so we really took that Squire study and modeled our study after that.
So what did you learn as you were building out the methodology from this? So you said you used the Squire as one of the frameworks. What did you carry forward? And then looking at that, what did you decide to modify?
Yeah, so the way that the study rolled out, as I said, I was getting a master's degree as well. So when we were designing the study, I was sort of using that study also as part of my master's project. So it ended up becoming my master's thesis. And so it ended up going through tremendous amounts of review from not only, my mentors at Children's Hospital of Philadelphia at the time, through the Penn folks, AJ and Nova, also through my coursework. And then I ended up submitting it as a grant so that it ended up getting peer reviewed at the NIH. And all of those sort of opinions got meshed together and allowed us to create the study that you see. So to answer your question, Mike, the Squire study was just so clean and very nice in that it was an evaluation of a diagnostic test. And it looked at the clinical exam test characteristics and then the test characteristics of point of care ultrasound. Now, one of the challenges that we faced in pediatric emergency medicine at the time was, as I said, no one was doing it. So no one really knew how to do it, right? And I was one person in the emergency department in my hospital that knew how to do it. So we had to then go and train all of the, the fellows that were going to partake and the handful of attendings that were going to enroll patients. We had to get acceptance from the department, and we felt that we needed to notify radiology in the hospital, and we sort of needed to get buy-in. So there were all these other hoops that we had to jump through at the time, just because it was so novel and so new, and people really weren't that comfortable with it at the time. And as I said, I just had this team of people who were really smart and really had the perspective and the methodological training to design a study that allowed us to, control for selection bias. So you'll notice in the study, we enrolled an arm of patients who never got an ultrasound because there just wasn't anyone there to do it. And so we were afforded the opportunity to sort of build a study that had somewhat of methodologic rigor to it.
So you mentioned that buy-in. This is something where this was not commonly being used already in the ED. How did you get that buy-in? What strategies did you find actually work to get people to start doing this?
So I think that at the local level, so the fellows and the attendings in the emergency department, I think, bought into it and were excited by it, and I think wanted us to be able to use it. At the time, though, the body of literature in pediatrics was very scant, and at the time, radiology was very skeptical of it, not unreasonably so. I think, there really wasn't much published. They didn't really know a lot about it. It wasn't commonly used in pediatrics. So I think that we ended up ensuring that the ultrasound exams were going to be done purely for study purposes, and that we weren't going to go and start using it as a tool without studying it first. And that's actually how we got sufficient buy-in to be able to do the study.
It's interesting. It's a little bit of the chicken or the egg. Am I going to prove the principle so that people do it? Or am I going to use this to form the use of it? One of the things that I feel like comes up a lot, and specifically when you're looking at abscesses, is this duality of your gold standards, right? It's easy if everyone got an IND, then you have a very clear endpoint of this. But you have this cohort that you're not going to stick a needle or stick a scalpel into something when they have what you believe is cellulitis and ultrasound. So how did you approach those patients, and what do you think is the best way of establishing that final diagnosis in the ones who don't get the IND?
Yeah, it was such a challenging thing to develop, right? Like what's your outcome measure going to be, and how are we going to define the reference standard? Fortunately, there had been studies done before. I mean, the Squire is one, where when there's not sort of a uniformly applied standard that everyone gets, then you got to get creative, right? And what's ethical, because we couldn't drain everybody. And so based on what we found to be, reasonable and what had been done in the past, we decided to do 48-hour follow-up. Now, the Squire paper is interesting because they followed patients up to 7 days. And our thought was we may be misclassifying a lot of patients as, false negatives if we let them go out 5, 6, 7 days. Now you're draining something this far out. Well, can you really say that they should have been drained a week ago? I mean, we know that this is a spectrum. We know that things progress. So we decided to, make a much tighter, shorter time frame. Obviously there's limitations to any of those that you pick, and you're going to risk misclassification on either end. So it's a trade-off.
I think that's a really interesting point too, because it's almost the challenge of, is it there or is it clinically there, right?
Mm-hmm.
It's the tree that falls in the forest. There might be a very, very small pocket of virulence that, well, it's probably gonna resolve with antibiotics anyways. So does it really matter? And potentially are causing more harm because we see it now. We see it, therefore we must stick a scalpel into it, whereas it would have done fine before.
Absolutely.
So,
absolutely.
Yeah.
I never thought I would spend so much time sort of thinking through all the machinations of and I don't think that when we designed the study that we really appreciated all of these different little hiccups of well, even if we see something on ultrasound, it doesn't necessarily mean that it needs to be drained. So how are we going to define that? And if you do drain something and you get a little bit of pus out, does that mean it needed to be drained, or would it get better with I mean, you can make yourself really, I think, crazy. And so, unfortunately, I think where we are with soft tissue infections, it's not as clean cut as something like, pulmonary embolism, for example, where you either have it or you don't.
I love that. I think we need more of that in research, the idea that certain things just aren't clear cut. We like dichotomization, that must be this or that, but it's not. A lot of stuff isn't. I might ever argue that even PE isn't necessarily, right? Does the subsegmental PE that's probably artifact, does it really? It's just, I love that nuance to it that you highlighted there, which is, there is some area of that, and you have to just make your decision and kind of stick to it.
Yeah. Yeah. At some point you have to just draw a line in the sand. You have to make a decision, right? You have to have a cutoff. You have to make these decisions, and some reviewer somewhere is going to pick it apart, but you have to draw the line in the sand.
There's always reviewer 2. Sometimes they masquerade as reviewer 3, but they're always there. They're just sometimes shifting around the order slightly. Yes. And so as we think about this, again, this is a landmark paper. If I'm now thinking about how I apply it clinically, how do you apply it clinically? Like, what are the key findings you want us all to, when we think about your paper, step away from and say, this is how if I didn't use this before, how I would use it to, alter my practice?
Yeah, so I will answer your question, but Mike, you said that you use this paper in your practice. So I'm going to be really curious to hear what you tell your trainees and how you use it. I will say that, interestingly, the findings of the study and how it played out and the way that we analyzed it actually, at least for me, have been applicable. And when we have clinically evident lesions where we say, this needs to be drained, trust it needs to be drained, or there's no way that this is this is clearly a cellulitis. Those are no brainers at the opposite ends of the spectrum. But when you're talking about those more gray lesions where I could go either way, I'm not sure, then I think there really is a role for ultrasound. And we've had those things happen. I will tell you an anecdote that actually did not involve point of care ultrasound, but rather was involving a radiology ultrasound that was done by one of my colleagues. And I happened to be reviewing that day on QPath. And there was a patient who came in. I don't really know where the lesion was. And I'm reviewing the ultrasound, and I see that the person it was a fellow who had done the study, and he had interpreted it as, I think he had said questionable fluid collection. It was this giant isoechoic abscess. And I said, oh my gosh, I hope they drain this. And fortunately, the patient was still in the ED, and I looked the patient up. They were still there, and I saw that they had gotten a radiology ultrasound as a confirmatory study, because it was a fellow who had done the original study. And the radiology ultrasound said no drainable fluid collection. And fortunately, the patient was still there. And I went up to the attending who was taking care of the patient, and I said, you need to drain this. like, what are you doing? And they're like, we're sending him home because radiology said there's no abscess. And I said, there's definitely an abscess. You need to sedate the kid and drain it. And they did, and they got a ton out. I ended up feeding that back to radiology, and they were very thankful. But I think it's another good point, because the attending said to me, I was surprised by the radiology interpretation. And I thought, wow, that is like the perfect example of what we found. If you clinically thought this was an abscess, drain it.
I love that. And it speaks to so many pieces. Part of it is knowing how to do the exam, knowing how to read our own images. It's not frequent, but every once in a while, I'll look at a radiologic image and have an overread. And I'll just see something that the other person did. And sometimes just because the patient's in front of you, right? That clinical correlation necessary, we get it. So we get to make that call. But calling back to your paper, one of the things I really like that you did is you talk about pretest. We don't do that often enough. And that really does affect things. In the clinically apparent one, where there's purulence exiting the skin, well, that's a very different case than focal tenderness of a patient and some non-specific kind of erythema, where you're like, I wonder if something's more is brewing underneath there. That really is just early cellulitis.
Right.
And I like how you separate out. One of the things that I will use this frequently for kind of my discussion with our early learners is just understanding nothing's perfect, right? That if we use ultrasound, you know what? Yeah, it's going to be wrong sometimes, but physical exams were wrong more often. And so in those clinical and clear cases, yeah, you know what? Ultrasound may be wrong sometimes. That's okay. And you can also override that because it's not a perfect test. But if you're relying on physical exam alone, you're going to be wrong more often. And so balancing the two is why I find it really helpful. And I love that there was a numeric quantification. We can actually talk about, here is the data on how sensitive, how specific our likelihood ratios and how they integrate.
Yeah, I like that. I'm going to use that. We're going to be wrong, but your exam is going to be more wrong.
It's all about being just slightly less wrong than the other option.
Right.
Small margins of victories.
Yeah.
And so I see a couple of questions already coming up in the chat, which is excellent. So I'm going to pull up the first one here. So Dr. Sang-Werner actually highlighted that it'd be interesting if we hit an RCT on small abscesses not identifiable by exam alone and see what the rate of resolution is for IND versus conservative treatment. Interesting. That would be a very cool study.
Yep.
Maybe we pose that one back an hour from now.
Let's do it.
Have it in our breakout from there. And I think Bryson Hicks highlights that, radiologists are human too, that we're all just subject to our own interpretations that, they might be different from ours.
Yeah.
I see here, Dr. Nikolai Schnicki highlights that, were there any, or ask the questions, were there any cases where the sonographer was convinced enough by the ultrasound that they felt like it was unethical to not let the treating clinician know, kind of like the QA case you mentioned?
Yeah, it's a good question. And the answer is no. No, we were, at the time almost banned from using this for medical decision making. And we had clinical equipoise going in. And so we said, we don't know if we're right? That's why we were doing the study. We didn't know if ultrasound, what we were seeing was truly an abscess or truly not an abscess. So it probably would have been unethical for us to have gone to the treating physician and said, this is an abscess. Some might disagree with that, but.
We have another one by Dr. Nova Penny-Bacco. I'm actually, as one of the other authors of the study, do you want to bring up your point?
Oh, Nova, do it.
All right. My question was, I'd be interested to see how often CAT scan undercalls a drainable soft tissue abscess. Anecdotally, I think that people rely on CT when ultrasound is the better test, particularly for things like a peritonsil abscess, where there's clearly a drainable pocket, but ultrasound or CT says it's a phlegmon or something not drainable.
Yep.
And we have another question up here from I'm gonna mispronounce your name, so I'm gonna let you do it.
Hello. Thank you for this great study discussions. And may I ask your opinion about the possibilities in that study could be related to the insignificancy between the evidence groups?
Between which groups did you say?
These evidence groups, because it's an unexpected result for me, and insignificancy there is not a significant difference between of the evidence groups by clinical evaluation and adding emergency ultrasonography. There is not a significant difference between them. And may I request your opinion about the possibility related for this result in that study? Because
So-
in other studies, there were higher than.
Right. So, so a couple of things. So in the clinically evident group, our sensitivity and specificity were very high already, just with clinical exam alone. So I think part of the findings of our study were that we had, these very Children's Hospital and pediatric emergency medicine physicians treating these soft tissue infections. They were very good at it. And so their baseline sensitivity was already quite high. So I think for the clinically evident group, we didn't show a significant improvement. Probably that had something to do with it. But as far as the group that was not clinically evident, the difference in sensitivity was markedly increased by about 43%. Yeah. Is that answering your question?
Yeah, of course. Thank you. And the last one, if please, is there any knowledge in drainage results of two groups? Is there any knowledge experience in that study about the drainage results of two groups?
I'm sorry, I didn't understand the results.
Drainage results.
Oh, the drainage results in the clinically evident versus non-clinically evident.
Yeah.
Right. So if I remember correctly, I think that the mean drainage, I honestly would have to go back and look. Thank
you very much.
Yeah, I'll go back and look.
Thank you.
Lots of great questions already. Thank you for everyone who's adding them into there.
Thank you very much.
Yeah, thank you.
And I think that other point you highlighted with the group that you're not seeing a significant difference in the one who have a high pretest, it's almost like the studies where you look at, antibiotics for abscesses. Is that if you have a high cure rate, you're not going to see much of a difference. It's hard to demonstrate that difference. And if you're really accurate with your history and physical exam on the obvious cases, it's so hard to improve upon that. It's almost like you need to massively power the study. And even then, does it clinically matter? Mm-hmm. Versus the ones that we all struggle with? That was, again, goes back to why I love that you kind of split it out by the clinical uncertain, because that's the ones I care about. Mm-hmm. The ones that are really obvious, I use ultrasound for an entirely different reason. And maybe I'll actually pass it back first and see, how are you using ultrasound besides diagnosis for your abscesses? Do you have any other applications you're using ultrasound for?
In our emergency department? Yeah, so we have 24-hour ultrasound, which I think does, when people ask me, like, what applications do you think are best for pediatric emergency medicine? And the first thing I always say is it sort of depends on your population, what conditions are you treating, what's the incidence of disease, and what kind of radiology resources do you have available? We're using it pretty routinely for bladder ultrasound for bladder volume prior to catheterization. Obviously, kids get cathed a lot, and there's nothing worse than a dry cath. So we do that a lot. I really, really love, and the exam that has probably changed my practice the most is the hip exam. When I have a kid who comes in afebrile who's limping, before I do anything else, I put a probe on, and if they have an effusion and they're afebrile and look great, I send a Lyme titer and send them on their merry way. So that's been a real game changer for me, because I noticed that a lot of my colleagues and a lot of our advanced practice providers will do like labs, and they'll consult ortho and all this kind of stuff, and x-rays, and I feel like it's really expedited my management. We use it for a lot of the routine ones that folks are familiar with: cardiac, fast, pneumothorax. We use it for intussusception pretty routinely as well, which is super helpful. I think those are the main ones, the rush exam.
And it's incredible when you think about how this started off with using ultrasound pretty infrequently to this, where it's, it's expanded out to so many applications and saved, unnecessary procedures, including vascular access for blood flow, for, blood tests and prolonged stays, and just how much it's really advanced. It's pretty incredible.
Yeah. And I mean, I'll be the first to say that emergency medicine has absolutely, led the way, paved the way, and has made it so that in pediatrics, we're even where we are, which is light years behind where general emergency medicine is, for sure.
So one of the things you mentioned early on too is the funding. You said that this was something you applied out for funding. Was this project funded? And, building on that as well, POCUS research is hard to fund. So what advice do you have for trying to get POCUS funding? Yeah,
it is. I think, so to answer your question, I applied for an NIH F grant. If folks are not familiar with F grants, is anyone familiar with an F grant? So it sort of precedes a K grant, and it's one of the individual awards that you can get. It's called the NRSA grant, and it funds you for an extra year of training before you become faculty. And there's a sizable amount of money available to help support the research, but most of the funding is salary support to fund that extra year of training, and they expect that you're going to take classes and sort of learn new things. So that's actually the year that I spent learning the bulk of ultrasound from Nova and AJ. And those kinds of grants are designed to fund the person and not so much the project. So I think the fact that it was, an ultrasound study, I really don't think that they were necessarily interested in that, but more in the potential for me. I think that it is a hard sell to some extent. I think that for POCUS research to get funded, you really need to demonstrate its impact in a meaningful way in terms of measurable outcomes. I also think that multi-center research is probably, arguably one of the only ways to get this kind of research funded. In pediatrics, it's a little bit different because the incidence of disease is so low already. So doing these sort of single center studies, unless it's something like soft tissue ultrasound where everyone's coming in with an abscess, it's really hard to have enough power to show a meaningful impact. So, I think studies with really good high impact clinical outcomes and multi-center research is the way to go.
I love that. And I think that's the area that we as a field need to be better at, right? More multi-center studies. Preferably not just, I have two hospitals I work at, and these are my two centers, is true multi-center. We have a broader external validity to it and can kind of prove these concepts out more.
Yep.
Let me ask one more question before we split into our small groups. And that's, you've had a lot of success doing a lot of really great work. What advice do you have for early researchers who are just getting into this?
Gosh, I would say, really careful planning up front before if you're doing a clinical trial, before you enroll that first patient, because you're so excited, you've been working so hard on this, you want to, get those patients enrolled. I think getting the study vetted by as many people as possible is really the way to go, because you'll be surprised at how in the weeds you can get, right, as the principal investigator, and lose sight of things that need to be addressed, and you don't want them to be addressed by the grant reviewer or the peer reviewer, right? You want to kind of nip it in the bud. So I think, having a nice team of mentors who probably are not all POCUS experts, right? Like that's not the team that you want. Having multiple people with multiple views and multiple areas of expertise is going to behoove you for sure. I think the other little pearl that I discovered almost accidentally is if you're creating a clinical trial, if you're designing a clinical trial or prospective study, especially if it's this big, multi-center study, one thing to keep in mind is you're collecting all this wonderful, rich prospective data. And so you want to really leverage that and take the opportunity to think through not just your study question, but all the other questions that might naturally follow it that you can answer with your study, right? The study is probably going to lead to other questions that will need to be answered with future studies. But I think that there's an opportunity to look at and publish other studies beyond just that primary study. And this is such a nice case of that, where I think in the end, we ended up publishing about 4 different papers in different journals based on the data that we had collected with this study primarily in mind.
I love it. So many rich pearls in there. The idea of the friendly fire team, the pre-review, having people who stepped away from the project who can lend some insights in that, and even just that concept of making it count twice or thrice or whatever the 4 version of that is for the publications of that. I think that's brilliant. Thank you so much for sharing your insights with that. I hope you're able to stay on for the rest of the second half of it.
I hope it was helpful.
No, this was excellent. And I'm going to pass along now to Dan Murch, who's going to. Thanks, Dan. A lot of great discussions. Our group, I imagine, similar in everyone else's. What I'd like to do with maybe the last couple of minutes of this is, if every group feels comfortable, maybe just sharing 1 or 2 key learning pearls, something you learned, whether it be about shoulder ultrasound as a technique in general, about the study design, how to analyze it, to help share kind of across the groups. If you're like, this is the thing that we learned that impacted me that I want to share with everyone else. And so we'll say, maybe as if the groups are still listed, I'm going to start off with the group of Dr. Kitty Burns.
All right, great. So we had some, good comments about some of the factors that contributed to the strength of the study. One of this being the fact that there was 1,206 patients enrolled in 6 months. And so we thought that was fantastic. And the fact that they were consecutive patients as opposed to a convenience sample, which we sometimes see when you're involving a study with a specialist. So I'm sure there's a lot of other points, so we'll leave it at that.
It's unbelievable how many dislocations they had there. This feels like it must have been the entire country. Like, I can't believe they had that many in 6 months. It's wild. And so as we go to the next person, next one I have is Dr. Joe Cola.
Okay, I didn't. So one of the things we talk about is like how, I don't know if anyone's ever tried to do any randomization or, to do consecutive enrollment is really, really high standard. That is unbelievable that they're able to do this. So it's like, I mean, everybody really liked this study just for that alone. And I think that was like one of the points we talked about. I'm trying to think, not much negative to say about this study. Oh, I personally like the fact, and I wrote this in the comment, how we're getting back to this idea of combining with your physical exam and your pretest probability. I was saying that I just have this theory that we moved away from that because like there's these interest groups trying to kind of like stop billing, and so we were moving away from an extension of the physical exam. And I think with the pragmatic study movement, like everybody started doing this stuff back again, and it kind of feels more comfortable because that's what POCUS is. That's what makes us unique. Otherwise, we're just kind of a less experienced, radiology sonographer, type thing. So that's what makes it unique to point of care. That's it. Sorry.
No, that was a theme across both these ones too, is the integration of the physical exam into the study design. And there is a lot of nuance to that from a billing standpoint, but ultimately we chide radiology about clinical correlation necessary because we are the clinical correlation. We should be able to integrate this because this is how we're actually using it. So I like that both these studies actually spoke to it, how we're using it in practice, as opposed to this approach as if we are radiologists walking in, scanning and walking away and not seeing the patient again. So I think that I like that broader applicability. It spoke to me as someone who's going to be an end user. Next one along, Dr. Russ Horowitz.
Hi, to build upon what Joe, well, first of all, we did comment that there are a gazillion patients, and that's amazing. The idea of using point of care as part of how you examine patients and take care of them is very logical. And I agree with the idea that we kind of got away from it as using it just like a diagnostic only tool, like a radiology study, but that's not real life. And using ultrasound in real life is kind of how we improve the care of our patients. One of the things, in addition to the details of the number of patients that we both really enjoyed, was that how they describe their approach. So using a transverse approach, sliding cranially to evaluate for fracture, combine some of the things that we do, the fracture identification and dislocation, and I'll incorporate that, I think, as part of my evaluation patients. And then also an anterior shoulder approach, which I haven't used very much, but other members of the group do, because often it's impossible for the patients to be comfortable enough to get a posterior approach.
I completely agree. And I think this is probably one of the best descriptions of the approach to a shoulder dislocation in any of the studies that have been published so far. They actually described it fully, where I feel like I could visualize the probe in their hands. Oftentimes there's this, here's how we found the dislocation, and then we assess for fractures, ... And you're like, okay, how did you do this? Because I need to be able to replicate it. And I thought they did a good job of actually telling me exactly what they did in a way that makes it much more tangible to me. Next one I'll pass along to is Dr. Amy Cole.
Yeah. So, I mean, I think we really enjoyed this study too. The one thing that we kind of highlighted in terms of the limitations that the authors brought up was the lack of determination who actually were performing the studies and like how many each of them did. Because if you had like a super user that was performing all the scans and created maybe a skew in terms of the results of the study. It was just kind of one thing that, it was really interesting knowing how good the sensitivity and specificity were for both the dislocation identification as well as the fracture identification. But also in general, like seeing, it was kind of a last minute discussion on application of, okay, would we actually need to still get the X-ray? But all came down to the institution and your ortho colleagues, and most likely they would be asking for that X-ray regardless.
Our group had the exact same discussion near the end that often challenge between, I know what I want to do, but once it's going to go to someone else, how do I balance those pieces of it? That is one of the things I love about the newer literature into focus for ultrasound for dislocations, is that they look at fractures, since I don't think most of us in the majority of cases are ambiguous about it when it's clinically out. And then we still get the X-ray to look for the broken bone. I think being able to demonstrate not just that first step, but they took it to the next level, saying, listen, you can also pick up any of the relevant fractures we care about, and everyone else, well, they're going to follow up anyways. It's probably not going to change much. So I think those are great points. Next, I'm passed along to Dr. Amy Marks.
Hello, everyone. So our group kind of touched on all of those same points also. Another thing we discussed was how we liked that in their methods, they actually mentioned that they were compliant with the consort statement and checklist for randomized control trials and the STARD guidelines. And this just makes it a little more standardized, and that the authors and investigators kind of went through these checklists and made sure that they hit everything to make it a great randomized control trial, including the flow sheet that you can see in figure 2 that is involved in all of these guidelines. And we also touched on the fact that we liked that all of the people enrolled did receive radiographs, because we think it actually just supported the use of ultrasound. So.
I think that's a great series of points. And I having been in that group too, I love the emphasis on figure 2 and just being able to see that flow. How many were initially identified? Why were they excluded? How many were excluded? To understand that they visualize yourself actually in the flow of that and be able to put yourself in the shoes of the investigators helps me understand how much I can rely on this information, right? Did they exclude a whole bunch of people because they thought the exam was going to be difficult, or because the patient was in too much pain? Well, that makes it harder for me to apply. And so being able to actually see exactly why people were excluded and how many people may have been lost to follow-up because they said, well, your ultrasound exam is taking too long, I'm just going to not do it. That affects things. So we don't see it as often as we should in randomized control trials and ultrasound studies, but I was glad to see it in there. Next one I have up is Dr. David Patel.
All right. So one unique part of this paper that we mentioned in our discussion was how they incorporated the anterior scanning approach. Most of the other literature focuses on the posterior. I like the addition of the anterior to specifically assess for fractures. So I thought that was a unique component of this that we briefly discussed.
Absolutely. Yeah. And for those who are, less familiar with it, there are two primary approaches to this. There's the anterior lateral and there's posterior. And I feel like most of us do the posterior approach. But I don't know if everyone actually scans the anterior plane to look for fractures. And I think it kind of even held my feet to the fire to remind myself that, yeah, it's not just scanning across the long to the bone, it's actually checking the anterior zone of it. So I appreciate that part as well. It's a great point. Last one is Actinian syndrome.
So as the last one, obviously lots of things have already been talked about. I will reiterate that our group spent a lot of time talking about how skeptical we were that they were able to accomplish this study, but just, with continuous enrollment and so many so many people doing it, but it's awesome, but we just spent a lot of time talking about that. And then I think one of the things we really liked about the study was that they used a reference standard of X-ray versus like a gold standard of CT, because none of us are really CTing our standard like shoulder dislocation in the emergency department. So it's really more applicable to our actual practice.
That's a great point. That's a huge point right there. Is that gold standard. We touched about it earlier a little bit with Dr. Marin when we were talking about our gold standard for abscesses. And for this as well, if you chose CT, you'd exclude a ton of people because most people don't get CT. I'm also aware of at least one randomized control trial or prospective observational study where they used a single view X-ray to diagnose it. And that's on the other end of the spectrum. We're like, that's not typical. We don't get single views of the shoulder. And that affects things, particularly because you miss posteriors if you're not careful with it. So I think that it just kind of speaks to, we should be pushing ourselves to make sure that the gold standard actually makes sense. And it's not either too inclusive like CT and you miss all the patients, or too, or less applicable, like a single view X-ray that doesn't really reflect what we do in practice. With that, I open up to the rest of the group. Any other thoughts, ideas, or feedback from the article that you feel like you wanted to share with the group?
There's one other piece of value that wasn't really talked about a lot yet, but rather than thinking about this as replacing the radiograph, I think of shoulder ultrasound as being used in conjunction with your standard evaluation, because rather than getting the radiology tech to come back over and shoot an X-ray, oh crud, we're not in yet, and then shoot another X-ray after you try again, it's going to take a lot of time. So you can use this to confirm your reduction rather than having the radiographs be performed multiple times, for instance, in your difficult reductions. So I think there's a ton of value there too.
I think if I can chime into, one of the things I'm thinking about from the method standpoint is this is a really phenomenal methodology that conforms to like community defined standards in RCT. But the biggest glaring limitation to me is that external validity and not going into detail about who these sonographers are, how much they're doing. And it's almost like point of care ultrasound has this extra set of things that we should probably be including in point of care ultrasound studies, and information on sonographers is so critical because it completely changes external validity if it's a bunch of ultrasound nerds like us doing it, or like your average emergency doc.
It's two huge points there. I think going to the first one too is how you use ultrasound can vary. We often treat it like it must be the panacea of all things because, well, we're sonophiles and we're nerds and we love you doing ultrasound for everything, but you can use it however it applies to you in your practice. If it is in the case, of Dr. Hicks highlighting out that you could use this to just confirm that it's in. So you're not resedating them or saying for X-ray for unnecessary images. One of the applications I really like, I was talking to our group about, was if I see someone at the bedside where the suspected dislocation, I'll take a quick look. If it's out, I inject them right then. So then they're at least pain-free, the spasm goes down, they feel better. I consent them for everything, including the reduction then. And the same thing, if I look and it's in, well, I go take a look at the AC joint and see if it's AC joint separation, and then I'm gonna get clavicular images. And I'm going to change my entire management based on what I see at the bedside before they go to imaging and get a bunch of radiation or get the wrong test. So that's at least been one of my primary applications. And then I think the other one that he kind of highlighted there too is in ultrasound, it is a user-dependent skill, and we need to know who the users are. I don't love the idea of clumping. We tend to sometimes be like, I'm going to be externally valid, so I'm going to have users from one end of the spectrum to the other who are both fellows, and then a resident who's never touched an ultrasound probe before. And that's not really useful because they get blurred in there, right? Instead of having like a clear kind of gray scale, everyone's the middle shade of gray, and I don't know what to do with that. And then we found the accuracy is not very good. It's mediocre because it's blurred. Or the accuracy is awesome because the fellow was here all the time and did all the scans. And really the resident did one scan, but it showed up as a group, right? It's like, have you ever seen some of these studies that do these histograms that kind of like plot it out and like, here's your false positives, you know, true positives, et cetera, by buyer user. I was like, that's amazing. Now I know what to do with that. But I find it really hard when they get blurred together because I don't know what it really means to me or to my faculty or to our residents, because they're different skill levels and may not apply the same. Any other final thoughts from the group? All right, well, thank you all, first of all, for being a part of this, for sharing your insights. Dr. Marin, thank you so much for sharing your insights and talking about your study and helping us to learn through, you know, both your design of it and what you've learned through the process. And for all of you for spending the first kind of hour with us. As a quick reminder, the second hour is optional, but if you have studies you want to talk about, whether your studies, other studies, we are here to have expert level commentary and feedback and help to kind of create this community of ultrasound researchers to help create that next level study. I'll pass it back to Dan.